This is a narrated presentation on an evaluation of the Southwark Digital Health Check service completed by the First Insight team with Southwark Council. This presentation will consist of an overview of the study background, the methods, key findings, conclusions, consideration for future rollout, and study limitations. Study background. With the NHS Health Check service, adults aged 40 to 74 years in England are invited to attend a face-to-face health check service at GP clinics every 5 years. This service aims to detect early signs of cardiovascular disease, type 2 diabetes, kidney disease, stroke and dementia. Behavioural support or further tests to reduce risk of disease are offered following the service. Within the London Borough of Southwark, between 2014 and 2019, 51.1%, and between 2022 and 2023, 58% of the eligible population attended a health check in Southwark. Those less likely to take up health checks are men, younger, and those from most deprived areas. Integrating digital technology in healthcare systems has been seen worldwide as key to driving efficiency and improving equitable access. According to a review conducted on digital healthcare has been shown to increase control and convenience for patients. It may be preferable to those apprehensive about medical appointments. It can foster greater feelings of privacy and overcome stigma around health-seeking behaviours. It can alleviate pressure from primary care services. It can provide greater flexibility in healthcare professional schedules. And finally, it can offer economic advantages compared to standard care. In January 2019, the London Borough of Southwark launched the Digital Health Check. This was used to explore a digital solution to increasing health check uptake, especially among those who need it most. The Digital Health Check was launched as an additional option to face-to-face delivery, with the potential to reach a broader audience, with a mode of delivery that overcomes barriers such as privacy concerns, stigma, and offer additional capacity to the NHS Health Check programme as a service that could be easily scaled. This diagram explains how the Digital Health Check works in comparison and in conjunction with the face-to-face health check. Firstly, starting in the top pink box, service users access the Digital Health Check through a link, which then brings them to the website. Here they have the option to book a face-to-face appointment, should they wish. Both face-to-face and Digital Health Check start with a health assessment, which includes the lifestyle risk factors and physical measures. For the Digital Health Check, service users may not know the values for the physical measures, but they can still proceed to the next section. For face-to-face appointments, they can get these measured during the appointment or be asked to return at a later time to get them done. This depends on the clinic. Following this, both health checks proceed to give the results of the assessment. For the face-to-face appointments, this includes results, advice, and signposts to relevant services. These may also be emailed to the service users afterwards, depending on the clinic. For the purpose of comparison between face-to-face and digital health checks, we define reaching the results page as a completed health check, with or without physical measures. For the digital health check, individuals can choose 2 health priorities to focus on and gain tailored advice on, depending on barriers they highlight for themselves. Examples of these health priorities can be finding out the values for their physical measures to increasing their physical activity levels. They are given signposts to health interventions or directions for the physical measures. That is the end of the digital health check. For the physical measures, service users can either attend a GP clinic, a leisure centre, or a pharmacy to get these measures taken. They might also choose to get a home blood test kit delivered. Once results are received, service users are invited to update their results on the Digital Health Check website. The study had several aims. The first was to compare uptake of the face-to-face health check and digital health check with face-to-face option and assess the extent to which the digital health check is effective at engaging those groups that have not been reached by the face-to-face health check. The next aim was to explore to what extent the service overall is effective at encouraging people to take positive health actions and whether this differs among those completing the digital health check versus face-to-face health check. The next was to look at the effectiveness of the digital health check in identifying those of increased risk, especially around physical health data. The next aim was to estimate the cost of the digital health check and face-to-face health check pathways. And finally, to understand service users and healthcare professionals' perceptions of both digital health check and face-to-face health check services. Moving on to the study methods. This was a mixed methods evaluation that used quantitative methods, health economics, and qualitative methods to address the study questions. Detailed methods are described later. This study took place between January and April 2023, when 9,000 eligible individuals in Southwark were invited to attend either a face-to-face health check or a digital health check. Following this, service users and healthcare professionals were interviewed about their experiences. Uptake and effectiveness of the digital health check service. Aims 1, 2, and 3. This slide breaks down the quantitative methods used in this evaluation. A random sample of 9,000 was drawn from all those eligible for an NHS health check in North Southwark between 24th of January 2023 and 18th of April 2023. 3,000 were randomised to receive an invitation to a face-to-face health check, while 6,000 were randomised to receive an invitation to a digital health check. These were also offered a face-to-face health check as an alternative if they wished. Data such as demographic information, completion of health checks, health check data, completion of different stages of the digital health checks, and data on GP appointment medications and referrals were collected from both the electronic patient health record system and the digital health check online tool. This slide shows the uptake of the health checks. Of those invited to the digital health check, 24% completed some form of health check. 11% of those invited to a face-to-face health check completed a face-to-face health check. 21% of those invited to a digital health check completed a digital health check, and a further 3% chose a face-to-face health check instead. Patterns were similar across demographic subgroups, with higher uptake for the digital health check. In general, uptake of any type of health check was higher among women and those who live in less deprived areas. A key difference is in ethnicity patterns. There was no difference in face-to-face uptake between ethnic groups, but digital health check uptake was higher among those with white ethnicity and lower for Black ethnicity. This slide shows an overview of engagement with different parts of the digital health check tool. 55% of those invited to a digital health check clicked on the link in the text message, and around half of those started the health check. 21% of those invited completed the digital health check, i.e. completed the health assessment section, the primary comparison point. 60% of those who completed the health assessment section went on to complete the support and advice section. When people didn't know their physical measures, i.e. their weight, their blood pressure, cholesterol or HbA1c, they were offered the opportunity to find them out and update their results. Only 7% went back and updated these. A similar percentage of those completing the face-to-face health check and the digital tool were identified as at moderate or high risk of cardiovascular disease. More people were identified as at risk of diabetes in the face-to-face compared to the digital health check. Please note that risk estimates depend on physical measurements, for example, blood pressure, cholesterol, and HbA1c. These are measured during the face-to-face health check, but in the digital tool, they are only entered if people know their measurements. A large proportion of people did not know. 75% did not know their blood pressure, and 90% or more did not know their cholesterol or HbA1c. This means that the risks from the digital tool are based on population averages, which may not be representative and is a limitation of the digital health check. For those who completed the digital tool, if they were underweight or with obesity, had high alcohol consumption, high blood pressure, high cholesterol, or high HbA1c, then they are recommended to make a non-urgent appointment with their GP surgery. 56% of users were recommended to make non-urgent appointments. Those who were severely underweight or had very high blood pressure, cholesterol, or HbA1c were advised to make an urgent appointment. Only 1% met these criteria. Of those recommended to contact their GP, around half did so within the time frame of the study. Please note that the numbers are very small for those recommended to make an urgent appointment, and so this estimate should be treated with caution. Finally, we looked at any further engagement with GP surgeries within the study timeframe in terms of appointments, medications, and referrals. All of these were much higher for those completing the face-to-face health checks compared to digital health checks. Aim 4. Estimated cost of the digital health check. We estimated the costs using data supplied by Southwark staff for the digital health check pathway, and data from Southwark staff and relevant literature for the face-to-face pathway. Costs were categorised between development, management, and operation. Development costs include those relating to the pre-study phases of digital health check pathway evolution in Southwark. Management costs include the project management and service design of the study. The estimated management costs were allocated pro rata across the 9,000 users in either of the digital health check and face-to-face pathways. Operational costs are those associated directly with running the study and include identification and invitation to participate in the study and delivery of the digital health check and face-to-face pathways. Digital health check pathway includes both its digital service and physical measures. We allocated the digital health check operational costs across 3 phases of the pathway, relating to the completion of the assessment, support, and physical measures. The face-to-face health check unit cost was estimated using the analysis reported by the Office for Health Improvement and Disparities in 2021. We estimated a potential scale-up scenario to illustrate how the costs may change if delivered over a larger population. We used ONS population data to estimate the Southwark target population of 107,000 and assumed that over 4 years, half these users would be invited to the digital health check and face-to-face pathways. We have assumed some economies of scale relating to costs. Costs were categorised between development, management, and operation. Development costs include those relating to the previous phases of digital health check pathway evolution in Southwark and were estimated to be £261,000. Management costs include the project management and service design and were estimated to total £80,720. The operational costs of the digital health check pathway were estimated to be £59,874 across the 3 phases of the pathway, relating to completion of assessment, which was 49%, support, 21%, and physical measures were 30%. The operational costs of the face-to-face pathway were estimated to total £20,309, and that includes the uptake and the actual health check. The estimated cumulative cost per user at each stage of the pathways reflects the level of engagement with users in the study period. The costs of a potential scale-up scenario for Southwark's target population based on the study's digital health check and face-to-face pathways. The economies of scale we have assumed reduce the management costs for both pathways and the operational costs in each of the 3 phases of the digital health check pathway. However, this estimate is based on the study's performance, and the digital health check pathway requires further development and piloting to achieve acceptable performance before assessing its potential scale-up. Aims to identify users at a high risk of conditions including cardiovascular disease and diabetes. This requires physical measure data to either be known by the user and recorded or collected and updated. This process is straightforward for users in the face-to-face pathway because it can be undertaken at the appointment with a healthcare professional. However, in the digital health check pathway, users have to proactively engage with one of the several options for collecting the required data and then update the results. Here, the face-to-face pathway identified more high-risk users, with all physical measures, weight, blood pressure, cholesterol, HbA1c completed, for a lower estimated cost than the digital health check pathway, which was not sufficiently developed. However, the digital health check pathway identified pseudo-high-risk users based on population-level risks at a lower estimated cost than for high-risk users in the face-to-face pathway. Aim 5. Understanding service users and healthcare professionals' perceptions of both health check services. We conducted semi-structured interviews with 30 service users and 8 healthcare professionals. Questions were included on understanding why service users chose a type of health check, service users and healthcare professionals' experiences of the service, and suggestions for improvement. Themes were then created based on barriers and benefits of both the digital health check and face-to-face health check services. This table provides an overview of the interview sample for both service users and healthcare professionals. We interviewed 12 males and 17 female service users. The majority of service users were over 60 years of age. 21 were of white ethnicity and 9 of other ethnicity. 15 had completed a digital health check. 11 had completed a face-to-face health check. 1 was unsure, and 5 completed neither health check. We interviewed 7 female healthcare professionals and 1 male, and all were over the age of 60. 4 were of white ethnicity and 4 of other ethnicity. Half of the healthcare professionals interviewed had only recently heard of the digital health check. The remaining half were not aware of the digital health check. 1 healthcare professional had experience of a patient who had used the digital health check, then returned to the clinic for follow-ups. The majority of barriers for the face-to-face service were the lack of available appointments at GP clinics for service users, and that healthcare professionals felt time pressure to complete a face-to-face health check with service users. Benefits included being able to have an immediate in-person discussion about health and results with a healthcare professional, and this was felt by both the service users and healthcare professionals. These discussions could also include adding context to a health assessment portion, getting immediate feedback on questions and concerns, and being able to schedule follow-up appointments immediately. There were a few barriers noted from the healthcare professional perspective on the digital health check. Please note, only 1 healthcare professional had direct experience of a service user who returned to the clinic following completing a digital health check, and only some healthcare professionals were aware of the digital health check service at all. A lot of the barriers had to do with the remoteness of the digital health check in general and the lack of face-to-face contact associated with that. Healthcare professionals were concerned about the accuracy of the submitted answers, and if the physical measures were completed at home or not by a professional, would they be accurately measured? Healthcare professionals were not clear on how the 2 systems integrate, particularly with integration of patient records from the digital health check to the face-to-face health check system. Healthcare professionals questioned if the digital health check would actually save time for NHS staff, as service users still need to return for follow-ups, and even to get their physical measures. Healthcare professionals were concerned if service users would fully understand the results, if not communicated by a healthcare professional. Benefits of the service that were noted by healthcare professionals were that the digital health check would increase awareness of the health check services overall. Similarly, from a service user perspective, barriers included lack of immediate face-to-face discussions, the forced response nature of the survey, in particular the lack of ability to discuss and give context to answers. There were mixed responses to the physical measures in the digital health check. Some service users said they would not perceive it to be a problem for themselves, but can see how it may be a problem for others. Others had a negative reaction to the idea of doing a physical measure themselves and not getting it done by a healthcare professional. Only one service user interviewed used an at-home finger prick test, and they found it difficult to use. Service users also perceived the results and advice section to be a barrier, as they were unsure of the meaning of the results and found the advice to be too general. Benefits of the digital health check from the service user perspective included its ease of use, its convenience. It allowed people to take ownership of their health. It potentially alleviated pressures within the GP clinics. It appealed to personal preferences, and the nature of the digital health check led to people feeling less judgment on their answers given. And considerations for the future. The digital health check may make people more likely to take up the option initially, but seemingly at the detriment of doing a more thorough face-to-face health check. There is a need for both digital and face-to-face health checks, as the digital health check is proposed as a complementary service rather than a replacement. Some people prefer online services, but there is a desire for face-to-face communication and input from healthcare professionals during the online health assessment. The digital health check does reach some groups more than face-to-face, but they tend to be more affluent and of white ethnicity. The digital health check does not reach those missing from the face-to-face health check. Ensuring the service is complementary to face-to-face health check and has rollout approaches that account for the fact that the digital health check may have better reach into more affluent white populations is important to avoid introducing inequalities. The estimated cost per pseudo high-risk user of the digital health check assessment based on population level estimates of physical measures was less than the face-to-face pathway. The collecting and updating of physical measures aspects of the pathway was included in this evaluation to test feasibility, but was less developed than other aspects of the pathway. The method of collecting the physical measures in the digital health check needs to be further developed. Service users do not know their up-to-date measures. If they do get them measured, the majority do not go back and update in the digital health check service. Service users and healthcare professionals have concerns about non-professionals doing the tests. The limited number of individuals who conducted and update physical measures raises the costs associated. All these have implications for identifying service users at risk. There is confusion with how the digital health check links to the face-to-face system. Better links between the digital health check and GP surgeries are essential to ensure follow-ups happen. And healthcare professionals need to understand the digital health check process. Service users engage with the support and advice section in the digital health check. And qualitative findings suggest while people engaged with it, they wanted even more tailored advice. It shows some considerations for future digital health check rollout design. Healthcare professional awareness of the digital health check needs to increase and improve. The digital health check needs to work alongside existing face-to-face services. Patient record systems between digital health check and face-to-face health check services needs to be better integrated, and healthcare professionals need to be made aware of this. There needs to be a pathway to ensure face-to-face follow-ups for high-risk individuals. The methods for collecting, updating and responding to physical measure data needs further development and piloting before potential rollout. Future research should model the long-term impact of the digital health check from a wider perspective. The following are key features that are inherent to digital delivery of the health checks. These can't be changed, but should be considered for future rollouts. Although the digital health check does give the opportunity for service users to contact their GP to discuss their health at a later appointment, the lack of immediate face-to-face discussion is apparent. This also has implications for point number 2, which is that service users cannot discuss their answers as they would during a face-to-face health check. Finally, according to the quantitative results on the uptake of the digital health check, it appears to appeal to certain demographics more than others. For example, white, younger, more affluent populations. The study had a number of limitations which may affect the interpretation of the results and findings. These include the small sample size for healthcare professional interviews and the difficulty recruiting healthcare professionals who had experience of the digital health check and who had experience of patients who had completed the digital health check. There were different invitation protocols for the face-to-face health checks and the digital health checks, which may have impacted uptake. Data on appointments, medications, and referrals could not be linked directly to health checks due to how patient record data are recorded. Face-to-face and digital health check data came from different sources, and so they were collected and processed differently, and were not always directly comparable. The final stage of the digital health check pathway relating to collecting, updating, and responding to physical measure data was not sufficiently developed to facilitate informative comparison with the face-to-face pathway or the scale-up scenario. There are also a number of assumptions in the estimated costs. These are detailed on the next slide. This slide outlines all the assumptions in the estimated costs. We would like to thank the London Borough of Southwark's Local Authority Public Health Team, the local GP Federation, and all members of the advisory group, including interested healthcare professionals, digital health check developers, public members of Health Watch Southwark, and other key stakeholders.